Welcome, and thank you for joining us this afternoon for Living with Arthritis, Non-Surgical Approaches to Hip and Knee Degenerative Disease. My name is Kathy Churn, and I am a Consumer Health Librarian at East Brunswick Public Library. Today's program is brought to you by Hackensack Meridian Health and the Libraries Just for the Health of It initiative to promote community health and wellness. Our speaker today is Elizabeth Bedara, DPT, MS, ATC, Manager of Rehabilitation Services at Hackensack Meridian Health at Raritan Bay Medical Center. Please be aware that this talk is being recorded. Participants' microphones are automatically muted and webcams off. When ready, the recording will be available at ebpl.org/YouTube. If you have any questions, please type them into the chat box. Our speaker will answer questions at the end of the talk. Our speaker will not be able to offer medical advice to attendees during this program. And without further ado, I'll turn things over to Elizabeth.
Thank you very much, Kathy. I really appreciate the invite, and I really thank everybody for taking their time for this presentation today. So just again, a little bit more about my role here. So currently, I've been at Hackensack Meridian Health at Raritan Bay Medical Center for about 10 years. And I work both inpatient and outpatient. So I'm really excited to share all of the knowledge that I have with all of you today. So like Kathy said, we're going to be talking about living with arthritis, non-surgical approaches to hip and knee degenerative disease. Okay, so the learning objectives today are to describe the pathophysiology of osteoarthritis, list pharmacologic and non-pharmacologic alternatives to surgery, understand the goals of physical therapy interventions, and discuss exercises that can help reduce symptoms and reduce pain. So just briefly, warning signs of arthritis. So when you should really go ahead and see your doctor. When you're having pain at rest and or with movement, swelling greater than 3 days or more than 3 times a month. If you're having stiffness, especially in the morning, lasting 1 hour or more, and difficulty moving a joint, especially when you're changing positions. So osteoarthritis is the most common form of arthritis, which we will be talking about today. It is characterized by cartilage degeneration, bone remodeling, osteophyte formation, and synovial inflammation. This leads to pain, stiffness, swelling, and loss of normal joint motion. Secondary issues with chronic pain, stiffness, and swelling also leads to depression, anxiety, decreased sleep, so a lot of other issues as well. So osteoarthritis is diagnosed by x-rays, which can be shown the joint space changes as well as bone on the x-ray. And then MRI shows any cartilage changes or ligament changes. Osteoarthritis affects over 32.5 million adults in the US and over 302 million worldwide. So OA is the most common joint disease causing disability, and over 303 billion is spent in care and lost earnings each year. So this is just a visual of osteoarthritis that I'm sure most of you are familiar with. This is what a healthy knee looks like. You have your nice articular cartilage, your nice joint space, your meniscus here, your ACL, PCL. And then this is somebody with advanced arthritis. So this isn't what everybody looks like of the whole spectrum, but this is, again, advanced arthritis. And you see the cartilage loss here, the joint space narrowing, as well as the osteophyte formation, which are bone spurs. And then over here in the hip, you'll see the changes in the bone here, the cartilage. So you could just see looking at it makes you feel pain. And then over here, the x-ray image, you see the number 1 is the joint space narrowing. And then number 2 is the osteophyte formation. Here on the outside part of the tibia, the front part of the tibia in this image, and then as well as on the patella. So lots of changes going on when you're having this osteoarthritis. So contributing factors to osteoarthritis are age, prior joint injury, Any kind of bone fracture, cartilage, or ligament problem that you've had previously can lead to more frequent arthritis or earlier onset of arthritis. Overuse, obesity, musculoskeletal abnormalities, malalignment, which are the malalignment of bone or joint structures, weak muscles, meaning if the muscles do not provide the adequate support, then poor alignment can result, which again can lead to that osteoarthritis. Genetics, gender, and environmental factors. So you can see here in red, I highlighted the modifiable and what we'll really kind of be talking about here, the things that we could change. So treatment considerations. There's a lot going on with osteoarthritis, and a lot of people try an alternative for surgery. So there's a lot of interventions. So it really is a comprehensive plan for the management of osteoarthritis, including educational, behavior, psychological, and physical interventions, as well as topical, oral, and intra-articular medications. So treatment decisions should take the personal beliefs and preferences of the patient, and really the clients and the clinicians and patients that engage in shared decision-making. It shouldn't be, a one-side clinicians dictating or patients telling the clinician. It really should be shared on what the best interventions are for each patient. So there's a lot of information on this slide. I'm going to present a lot of this information from the Clinical Practice Guidelines Recommendations for Osteoarthritis from the American College of Rheumatology that was published in 2020. So they assessed all of the research, randomized clinical trials about many interventions for osteoarthritis. And they broke it into pharmacological approaches and then physical, psychosocial approaches that we'll discuss a little bit later. So first, to decipher some of this darker green is what they strongly recommend as interventions. The lighter green is conditionally recommended. On the right side here, the darker red is research showing that there's not enough evidence pretty much. So here they're saying strongly against, and the lighter red is conditionally against. But again, not that these pharmacologic approaches are negative or have negative results. A lot of it, there's just not enough research for it to be strongly recommended or conditionally recommended yet. A lot of these studies have small subjects, or the interventions are over a small period of time, or the significance of the results are not enough to make it statistically significant, or there's just one study that may show results, but not enough studies to show that it's the best course of treatment at this time. So a lot of this in this red is based on just lack of evidence yet. But again, there's constantly research being done and more evidence being published. And, so we're keeping up with the evidence too. So this is published in 2020, and I'm sure by now there's been more research on many of these pharmacologic approaches that may be in red here. So let's go to a couple of the pharmacologic therapies that are strongly recommended. The first is oral NSAIDs, those being your ibuprofens, your naproxens, your disaflonics, sorry. And then these are established as a strongly recommended for short-term efficacy. Dosage should be as low as possible. They're for short-term use. And also you want to make sure the clinical considerations are your patient selection. You also need regular monitoring for potential for adverse effects. So any gastro, some GI, cardiovascular, renal side effects. You want to also be aware of potential drug interactions with any oral medication. But this is the first that is strongly recommended for pharmacologic therapies. The second one is topical NSAIDs. They are also strongly recommended. They reduce the systemic exposure that an oral NSAID enters. They're usually well tolerated. And some examples of these are, again, the diclofenac gel. It's a gel, it's a liquid, and there's a patch. So these are just some examples with the branding names, but there's also others available. Usually these are prescription. There's also the topical capsaicin, which is over the counter, and this is also conditionally recommended. So these are also some options rather than oral medication for pain relief and anti-inflammatory for knee and hip arthritis. Other pharmacological therapies. There's other medications that you could see here. The duloxetine is conditionally recommended for chronic pain. This is not like a first choice medication. There's also not adequate evidence for pregabalin, gabapentin, selective serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, and the tricyclic antidepressants. They did list tramadol here as conditionally recommended for those who can't use NSAIDs, for those who really have no available surgery options, and if other therapies are ineffective. We really do worry about the addiction potential for tramadol. And then other pharmacologic therapies that include intra-articular injections. The first one, which is strongly recommended, is the glucocorticoid injections. It is established as strongly recommended for short-term efficacy. Although the data is strongly supporting this, there's insufficient data to show short-acting over long-acting preparations of the medication and low versus high dose. So again, this kind of comes to your physician and what they're recommending. But overall, this is strongly recommended as an intervention for decreasing pain, increasing function. For the hip, it is recommended that is ultrasound guided injection. And it is also recommended over the other intra-articular injections that we're going to talk about in a minute, or right now. The other intra-articular injections are actually all in the red. Again, there's just limited evidence. These research articles, they're very small, or there's just not a lot of articles showing the same treatment plan regarding the timing of the injections, when they're injected. And because the research is not consistent from study to study to study, it's not enough science to say that this is the best course right now. So again, with more research, it might show more benefits, but we do have a lot of patients that get these intra-articular hyaluronic acid injections, also called viscosupplementation. So with these, these injections are fast acting. They help to lubricate the joint. They do provide pain relief. The pain relief is approximately lasts for 6 months, and you can repeat 3 times. So it's over 18 months. It is covered by insurance. The cons to this are the effects do wear off after time, and it's not curative or reparative. It doesn't help improve the cartilage. It doesn't regenerate anything. It's just for pain, improving the lubrication of the joint. And there could be allergic reactions. So there are also 2 other types of intra-articular injections. Their first one is prolotherapy, which uses a dextrose injection. It helps to create the inflammatory process to help restore cartilage and improve healing of the area. So again, it is considered regenerative in nature. It goes through what we call the proliferation phase of healing, hence the prolotherapy. And then also platelet-rich plasma, which they take your blood, they do what they do, they spin it, and then they re-inject the platelet-rich plasma into the area that's affected in hopes that, again, it will recreate healing. Other types of intra-articular injections would be stem cells, embryonic, adipose, bone marrow, or cord blood. Again, this one, the stem cell and platelet-rich plasma, again, strongly against, only because of the lack of research out there right now. Just to go over the pros and cons of these intra-articular hyaluronic acid, the intraoperative, the prolotherapy, intra-articular, not operative, prolotherapy and platelet-rich plasma. So the prolotherapy, both of them, they're non-surgical. So it's a long-term solution for chronic injuries. It restores healing in about 2+ years. It is safe. There's no other pharmacological substances entering your body, and it is cost-effective versus surgery. Although, because the research isn't there yet, it is pretty costly to the patient. I don't think it's often covered by insurance. It's also slow acting, so it's 1 to 3 months max per injection, and it can take up to 6 months for maximal results. And again, multiple injections can be painful. And again, talking about keeping up with the research, this article was published in 2019. So after all the research was completed for the other study that I was presenting. This article was a meta-analysis comparing platelet-rich plasma versus hyaluronic acid injection in patients with knee OA. And they looked at 15 randomized controlled trials, which is the gold standard for a research study. And I found that PRP injections reduced pain greater than the hyaluronic acid injections at 6 weeks and a 12-month follow-up. So again, the research is still growing on all these interventions as well. So we see people all the time with some of these different injections. Some do well, some do better. For some people, it's worth a shot as they don't want surgery, but none of them, in my experience, have made things worse. It's just a matter of how much relief you're going to get. That's why the evidence is just not strong enough right now to say that, yes, this is the way to go. I'm just including this here because some patients do come to us asking about the use of CBD, whether it's the oil or the lotion, pills or edibles. So I did include this in here for your information as well. But as I have on the bottom, you need to make sure you're talking to your doctor before any of this. But the Farm Bill in 2018 changed the law to distinguish the hemp from marijuana, the clinical compound found in the cannabis plant, but it doesn't have the THC. So, patients ask about this, and we usually recommend, obviously, back to the doctor, but we do see people, helping with pain. So you just need to make sure that, the state laws vary on legality. New Jersey has a comprehensive medical cannabis program. You want to make sure these supplements are not regulated. You want to make sure you understand the good manufacturing process and it has a certificate of analysis. And obviously the long-term effects are not well researched. If it is ingested, you want to make sure if you're taking other medication, it could potentiate other medications. So it could have those enhanced effects. And again, talk to your doctor. And just another one, a more herbal side of things. This is the arnica herb. Some patients use it. They have the lotion and the gels and the ointments. This is just an FYI, but as an alternative for some people, if you're looking for something else. So this is more into what I do, but I did want to present all of the pharmacological information because it's very important to understand those interventions as well. So again, lots of information here. This is also, again, from the American College of Rheumatology 2019 Clinical Practice Guidelines, Recommendations for Osteoarthritis. And the darker green is interventions that are strongly recommended, and the light green is interventions that are conditionally recommended. So the first one being exercise, strongly recommended. Self-efficacy and self-management programs, strongly recommended. Weight loss, Tai Chi, the use of a cane, or a patellofemoral knee brace, all strongly recommended. Conditionally recommended are heat or therapeutic cooling, cognitive behavioral therapy, acupuncture, kinesiotaping, balance training, the patellofemoral knee brace, and yoga. And on the other side, again, due to evidence and research and outcomes, the TENS is strongly against, and then conditionally against is manual therapy, massage therapy, modified shoes, wedged insoles, and this would be ultrasound. So again, it's just the research is not showing enough significance. But again, not to say these things that you can't try. So we'll go over some of these. So exercise. It's the best treatment for osteoarthritis. So when you talk about exercise, it's recommended aerobic exercise, 20 to 50 minutes, 3 times per week at your target heart rate, either walking or cycling. Also can be combined with strengthening. You can use isokinetic strengthening, which is the use of weight machines, resistance exercise training with or without the bands, and isometric strengthening, which means we're just strengthening in one particular range. Also, neuromuscular re-education training improves strength, improves sensory motor control, and improves functional instability. Aquatic exercise, also conditionally recommended. But here's the kicker though. So exercise, really the best intervention for osteoarthritis. But I'll read the bottom one first. While patients and providers seek recommendations for the best exercise and the ideal dosage, meaning duration, intensity, frequency, current evidence is insufficient to recommend specific exercise prescription. And this is because every patient is different. I'll read the first one now. Although there is currently insufficient evidence to recommend one form of exercise over another, patients will likely benefit from advice that is as specific as possible, rather than simple encouragement to exercise. Given the wide range of evidence-based exercise interventions shown to effectively improve pain and function in OA, all patients should be encouraged to consider some form of exercise as a central part of their treatment plan. So I'm going to go over some things later, but this is really the reason that we do what we do as physical therapists. We evaluate, we come up with a treatment plan, and we initiate interventions for what we find. Every patient has different deficits in range of motion, in strength, in the balance between, different muscle groups, making sure their biomechanics are optimal. So that's why it's really important for patients to try to seek physical therapy, even if they do opt for surgery, to try physical therapy as a first intervention, because sometimes you have deficits and imbalances that you may not even realize are contributing to your osteoarthritis symptoms. And it's not to say that after surgery you might still have some of those deficits and pain if you have an unresolved issue in another part of the body. And I'll go over that as well. So exercise is the best intervention, but again, as specific as possible. So as we go through the information from the study, I'm just going to review some of the other non-pharmacologic therapies. This was sorry, I'm trying to find it now. It was recommended, strongly recommended, I'm going the wrong way, the tibiofemoral brace. So there's a couple of different kinds, but what they do is they provide more of the lateral stability to the knee. that knee osteoarthritis really affects the medial side of the knee most often. So that's why you have the staplers on the inside part there. Again, they're very cumbersome, but some people find that they're very effective. Again, another option for people to try. And this is a patellofemoral knee brace. It helps to stabilize the patella during knee movement. Okay, more pharmacological therapies. So heat, again, conditionally recommended. It's a natural muscle relaxant. It allows patients to improve function during the session, as well as ice. It's a natural analgesic and anti-inflammatory. Even though some of these are conditionally recommended, any way to avoid the need for oral medication, especially with chronic pain, anything as simple as heat and ice is definitely something worth trying. The next one is kinesiotaping. Again, another alternative we use. We'll use kinesiotaping for edema control. We'll use it to help facilitate some muscle groups that aren't working biomechanically like they should. Or we could use it to inhibit muscles that maybe on an opposing side are overactive or tight. So we could use this for a lot of different interventions. Again, based on the patient presentation, symptoms, and evaluation findings. Okay, so going to the low quality evidence, strongly against the use of TENS, conditionally against the use of manual therapy, massage therapy, modified shoes, and wedge insoles, as we had mentioned earlier. So the thing about the TENS is that we use it very, very often. And this is just one, like we talked about, how the evidence is continuing to show different things and new things. So this was just one article from 2020 that looked at TENS with therapeutic exercise versus therapeutic exercise alone. So the TENS and the therapeutic exercise performed better only at 4 weeks, and there was no difference at 8 weeks. But we use the TENS most often in the role of acute pain because the patient may be able to tolerate the rest of the session, being able to participate in more exercise, more strengthening, more range of motion exercise, to then have more functional goals. All because the TENS does not really relieve pain more than half hour, a couple hours typically, but it allows us that time frame to really have more beneficial interventions. And there are TENS machines that people could take home. So if you had a home TENS, you could use it when you're performing functional tasks. So you have improved function while doing something with less pain. So again, it may not improve pain in the long run or some of these quality metrics in the long run, but if you're trying to improve pain right now to get XYZ task done, then that's where we use it the most. But we also use electric stim, not TENS, but electric stim. We use it for neuromuscular education, so neuromuscular electric stim. And we use this sometimes if we find imbalance of the muscle or deficit in strength, we'll use this at MES. Okay. And just reviewing some more non-pharmacologic therapies, when you look at insoles, I went to a course who had presented these 3 options. So I'm just forwarding along this education information that I had gotten. And the first one that they recommended was the New Balance Pressure Relief Memory Foam. It's more shock absorption. It's accommodating, so it's moldable. It's not too rigid. The next one is Sole. It's a heat moldable. It does control some of the foot, so it's in between that rigid and more shock absorption, so it's right in the middle. And then the Super Feet, which is that comes in blue or green levels. It's more of a semi-rigid. It helps support the foot. So if there's weakness and instability, this would be the way to go. I have no idea what cost is on these, but this is just information that was provided in another course that I'm passing along. So goals of physical therapy. We want to control pain, reduce edema, reduce myofascial restriction. We want to improve the strength, primarily of the quads and the glutes. We want to increase range of motion and improve muscle flexibility and muscle length. Again, primarily of the hip flexors and hamstrings, as we'll show in a second. Okay. So understanding muscular connections. So this is kind of very important just to understand when you're coming to therapy what you're working on. Yes, you have pain of the joint. Yes, the x-ray shows the narrowing. So the arthritis is there, but you also have this vast support system of muscles around the knee. You have your quads in the front, which over here you could see this picture, which is broken up into different divisions. So you have your rectus femoris here in the middle, your vastus medialis in the middle, on the medial side, and then your vastus lateralis on the outside. So again, these are big muscles, all help control the function of the knee. Your quads extend the knee, but they also flex the hip. So they, your rectus femoris functions at the knee and the hip. So again, if you're having knee pain, you want to look at how the hip is functioning as well. And also to look at the hip flexors. So your hip flexors here come from your vertebrae. They attach onto the pelvis and then onto your femur here. So if there's something going on with your hip flexors, if they're tight, for instance, they're also going to affect how that femur is moving, which then affects how your quads are functioning and the biomechanics of your knee. So as I tell many of my patients, that everything is connected. So you don't really want to get tunnel vision just looking at the knee and treating just at the knee. You want to make sure you're looking at the whole lower extremity and really the whole body, as you'll see in a minute. So this is just a picture of the hip extensors. So you have your glute max here, you have your hamstrings coming down, also connecting at the knee, also connects at the hip. And then your deep rotators, and then your gluteus medius here, which is removed. Is also important in stabilizing the hips as you're walking. So if your hips aren't being stabilized, you may be putting more pressure on one knee versus the other as you're walking. And again, too, you have your your gastrocsoleus down here. And you could see also connecting to the knee. So your hamstrings are here in the back, gastrocsoleus down here. If these muscles are tight, then again, it's pulling here at the knee. So again, really need to look at everything that's going on. And then also understanding fascial connections. So really your fascia is something that encases all of your muscles, but you have a couple more prominent fascial lines. And this one here I find very interesting. So this one goes from the bottom of your foot all the way up through your lower extremities, passing your pelvis here, all the way up your back and inserting in your occiput. So here, obviously you don't have to do this now, but just as an exercise for after this just to demonstrate the concept of what fascia is. So you would stand up, you're first going to try to touch your toes, see how much restriction you have. Then you're going to take a couple of minutes and you're going to roll out the arches, the bottom of your foot with either a golf ball, tennis ball, lacrosse ball, something. And then after you do that, try again to touch your toes and see how much further you could reach down. And that's because you're releasing some of the restriction in the bottom of the foot, which is therefore connected to this entire leg, to the hip, to the back. So it just demonstrates, again, how everything is connected and really need to looking at the big picture and not just the knee when you're having knee arthritis or the hip. Sorry, I may have focused some of this more on the knee. But again, it's the same thing with the hip. You're really looking at the strength of the glutes, of these deep rotator muscles, your gluteus medius. Again, like I said, if that gluteus medius is weaker when you're walking, it's not stabilizing. So again, your biomechanics become off. So just to demonstrate a little bit again of this biomechanics, what we're really looking at in a physical therapy evaluation, we're not just looking at the knee, we're looking at the big picture. And sometimes this is a typical presentation of people also with hip and or knee arthritis. If a patient, and again, which came first, the chicken or the egg, it's kind of in this situation as well. But once one thing goes out of whack, these the way that these muscles work together, they all kind of go astray. So what this is showing us is, I'll use this one first as an example because we see this a lot. If somebody has tight hip flexors, your iliopsoas, your rectus femoris is tight. I'm going to flip to this image over here. Unfortunately, it's in the other direction. But this top left picture, if the pelvis is coming forward, your hip flexors and quads and rectus femoris, because that's the one that connects at the hip and the knee, is tight, that pelvis is going to be coming forward. We'll go this way. So as a result of that, if you think about how that pelvis is functioning, if the hip flexors are tight here, it's bringing the whole pelvis forward. So then on the opposite side back here, your glutes then become inhibited because now your muscles want to, they force produce at this happy position here. Once they're stretched out this way, their ability to force produce is it's very difficult. It's inhibited. You can't force produce. So then it becomes very weak. And then you get these imbalances, and then your biomechanics become off as well. So if your hip flexors get tight, then your glutes are weak. You're not stabilizing. Then what happens on the other side is your erector spinae then become tight as well. And then your abdominals in the front, if that pelvis is coming forward, they also start getting stretched out. And again, they're inhibited. Now they're becoming weak. You just can't stabilize. And if you're not stabilizing at the hips and the core, your shock absorption then sometimes comes down through the knee. And then it creates a lot of other dysfunction. And again, some of this is associated with knees as well. A lot of people, as we get older, become a little bit more sedentary. The more people sit down, the more those hip flexors get tight. And it's not really a muscle that people typically are like, oh, I'm going to go out and stretch my hip flexors. And again, sometimes people have weak glutes to begin with. And then because they're weak and they can't stabilize, the pelvis just comes forward. And then those hip flexors naturally get tighter again, and those abs get weak, and your erector spinae back here get tight. Same thing just to demonstrate too in the upper body. As you know, as people age, gravity brings us forward. Our anti-gravity muscles get weaker. So anti-gravity muscles meaning your quads, your glutes, your traps, they're all your anti-gravity muscles. So your head comes forward, your pecs get tight here in the front. Again, then inhibiting those muscles in the back. Now those back muscles are all stretched out. They can't possibly work. So we need to release, we need to stretch those pec muscles as we work on strengthening those posterior muscles. So together, as we increase that range of motion, we could get those muscles stronger to get better positioning. And again, on the other side, those deep neck flexors, you know, your posture, those deep neck flexors work happy here. As you're coming forward this way, again, they're all stretched out. There's no way that they could force produce at that position. And of course, as you're here, those upper traps get very tight as well. So just to, big picture things, just to look at things a different way and how you could look at how everything is connected. So, even if you have this pretty significant arthritis, there's still other things that we may be able to work on to relieve maybe the stress that we're putting on the knee. If we have those tight rectus or tight hip flexors, they're every day it's just pulling. If we work on stretching them out, strengthening the glutes, then your hips and your knee get into a little bit better position. And then this is just echoing the pictures on the left. The tightness here, and then this is just a happy position. As the hip flexors release a little bit and the glutes get stronger, you get in that better pelvic position. Okay, and again, as the research has shown, there is no gold standard for, okay, if you do this exercise, your arthritis will get better. So again, like I said, your quads do knee extension, hip flexion. So you'll see in this bottom right picture, they're doing a straight leg raise, works on quads, works on hip flexors. But again, you want to make sure that all those parts of the quads are working symmetrically together at the same time. So if you have the medial osteoarthritis, that medial part of the muscle might not be functioning the way it should be. So going to therapy, we could, do the neuromuscular re-education. We could do education through feedback, through the electric stim, through visual, and even just comparing the difference or what, not normal, but what improved function looks like versus what some people present with. They're just not aware. So even if you're doing these exercises thousands of times, if you're doing it non-optimally or not recruiting in the correct way, not to say they're worthless, but they're not benefiting you the way that they can be if you get that skilled intervention, that one-on-one care that's patient specific. So as we talked about, you could do machines, you could do exercises with resistance, you can do things sitting, standing, with the ball from a chair. These are concentric exercises, meaning the muscle is getting shorter. This is, can't see the whole exercise in this picture, but on the steps, we're doing like a lengthening exercise. So eccentrically, there's a lot of different exercises. And that's why it's very important to see a therapist, because some of this does become overwhelming. Oh, what's the right thing to do? What's the best thing to do? But that's why we're in our field, because we help people identify some of these muscle imbalances and dysfunction. So these are some examples just for quad strengthening. And based on what people present with, we would do different exercises. It's very patient specific. So again, what we do often notice that the glutes become weak, more on one side than the other. Again, whether it's because they have that pain, that weakness and inhibition forms, but there's usually some kind of inhibition due to something else going on. So these are just some glute strengthening exercises. So hip extension exercises. You could do them standing, laying down. Sometimes when patients have tightness elsewhere, we'll stabilize on the treatment table, because sometimes people go to bring their hip back and their trunk goes all the way forward. So in order to compensate for that and really get some isolated hip mobility, we'll stabilize over the table. Again, other exercises in quadruped here, your glute med also helps do some abduction, rotation. So standing, this is another exercise that I really like for some stabilization. It works on that hip stabilization and also for hip stabilization. So there's a lot of exercises, and again, overwhelming. You really need to just come see us, and we'll really get you on the right course, in addition to the aerobic exercise. And again, just some general stretching that you may see. This is quad stretching. In standing, In laying down, you're going to be stretching the quads in the front. This here is your hamstring stretching. There's lots of different variations, but this is just a couple pictures. And then this is some hip flexor stretching. You know, over the table here, you're really working on, because you have to stabilize those vertebrae. And then stretch those hip flexors here. And then also you could do it. Some hip flexor stretches are a little bit advanced. That's why we try to modify things. But that's why we need to see you to make sure we doing the correct exercises and modifying it safely and appropriately. And this is just some glute stretching here, all the way on the right. And just, you know, amongst the opioid crisis, we really want patients to comfort therapy first. You know, really medication is, it doesn't fix any underlying biomechanic deficits, strength deficits, you know, imbalances. It doesn't fix any of that. So, you know, your pain won't necessarily get better because you're not doing anything biomechanically to help it better. So therapy is the best first option. And then I did a little post test, but we don't. So which modality has the best evidence for improving symptoms of OA? So obviously we went over this a lot, but exercise. Exercise is really the best. Which interventions are strongly recommended by the American College of Rheumatology? So we didn't go over these as much. I guess I skipped through some of this. But it is all of the above: exercise, weight loss, Tai Chi, and self-efficacy and self-management programs. Tai Chi, there's a lot of evidence on Tai Chi, which is very interesting. But because there's a lot of evidence, it shows the effectiveness because there's so much research. And it really works on slow motion, a lot of weight shifting. And when you're weight shifting in a slow motion, kind of, you really have to work to engage those muscles more adequately. So that's why it's shown to be very effective or strongly recommended. Which pharmacological modality is the best evidence of improving symptoms of OA? As we said, those NSAIDs, oral and topical. And then weakness of what two muscle groups occurs in the lower cross syndrome. So that's what we saw that picture of. It's called lower cross syndrome or upper cross syndrome. And the weakness is of the glutes and the abdominals, because as that hip comes forward, the tightness in the hip flexors and tightness of the erector spinae results in weakness of the abdominals and the glutes. Okay, so I also put some information here too. So these are for I'm from Hackensack Meridian at Raritan Bay. Hackensack Meridian is pretty much throughout you know, the more eastern side of New Jersey, from Hackensack down to Jersey Shore and kind of everywhere in the middle. But these are our 4 locations associated with us. But if you wanted to go to another Hackensack Meridian location, you can also call this phone number. It's just a centralized access for scheduling. We have locations in Perth Amboy, in Old Bridge, in Woodbridge, and coming soon. We've had a location under construction for a couple months, so it's hopefully going to be opening next month. And that's on Cranberry Road in East Brunswick. We also have other resources within the hospital. So we talked about, I didn't talk about as much as I thought I was going to, I must have skipped it, but about weight loss. And we do have registered dietitians within the hospital that do see outpatients. So, you know, if you come with a script from your doctor, you could also call this number to schedule for dietitians. And then also within Raritan Bay, we have an integrative medicine team, and they also do free community seminars. So that was the website that maybe you could access. But also, if you just go to the Hackensack Meridian and search like classes and events, integrative medicine, she does meditation and yoga. You know, this is just once a month. But if you're interested in just a little bit of doing something else, to see if that may help as well. And then some references, but I'll go back to questions.
Okay, great. Thank you, Elizabeth.
I hope everybody got all that. I know it was a lot, but there's just so much information and so much more than just I have osteoarthritis. So
Yeah,
thank you all for your patience.
thank you. And then, do you have time like for a couple questions?
Oh yeah, I have time.
Okay.
You guys.
Okay, so I'll read off some of the chat questions. So someone was asking, what is the difference between OA and RA?
Yeah, so osteoarthritis is really the bone on bone arthritis from the age, from wear and tear. Rheumatoid arthritis, it's just a different, it's more genetic, but I focus this more on osteoarthritis. But yeah, rheumatoid arthritis, a lot of the same interventions for rheumatoid arthritis as well, except like the gold standard for OA, if you can, is a joint replacement. For rheumatoid arthritis, it's not as much. It's more systemic, and you'll have it mostly of the hands as well as the knees, and it's systemic. Whereas osteoarthritis can affect multiple joints, but typically it's for people, it's one joint, maybe one joint, and then another joint like 5 years later, but it's typically isolated.
Okay, thank you. And is scoliosis considered a musculoskeletal abnormality? And then can it contribute to osteoarthritis?
Absolutely, absolutely. Anything that alters your biomechanics of your hips and your knees and your feet can contribute to osteoarthritis, because you're just, over the years, the way that you're wearing on your joints, it might not be optimal, or you're wearing more on your short answer is yes. There could be a lot going on that can create some kind of biomechanical imbalance.
And then why isn't more research being done on regenerative and stem cell therapies?
I think it is. It's coming out. It just, what this article had presented was there's a lot of different treatment regime differences. Like there's a lot of variation in how they're injecting the stem cells, or there's just a lot of, there's studies, but there's nothing consistent enough to say, okay, this person did this intervention with this. It's kind of like exercise too, where there's no, like, when we look at exercise, you could look at so many different variations of exercise that sometimes it's hard to say like that's the best exercise. So I think they're catching up with it with regenerative and stem cell therapies, trying to have a consistent treatment intervention. But again, I think there's more work coming, but based on this article that was published in 2020, but really the research was from 2017 and 2018. But it's just a lot of consistency of interventions and having it be specific enough, and small study groups.
Okay,
Thanks.
thank you. And then would exercise cause more pain because of the rubbing of the joints? Would that cause more pain later on?
So you're not going to make anything worse. Some people do have more pain while doing some exercises, but that's why when you could come for therapy, that we tailor everyone's exercise program to what they can tolerate, and also do other interventions too, like we talked about the TENS, because doing aerobic exercise like the bike especially is shown to help improve the symptoms of osteoarthritis.
What is the difference between TENS and eStim?
It's the same.
Okay.
Well, TENS is one, it's the transcutaneous, it just affects the sensory part of the nerve. But eStim as a whole, electric stim, there's different variations of it. So TENS is always eStim, but eStim is not always TENS, if that makes sense. So eStim, we could do different settings like a neuromuscular re-ed or a Russian or a high volt or something like that. other parts of E-stim, but TENS is E-stim.
And then if non-surgical approaches aren't working, what success have you seen with patients who have gone to complete knee replacements?
Yeah, I mean, knee replacement is the gold standard for somebody with advanced osteoarthritis. Not everybody is a candidate for knee replacement or hip replacement. So it depends where you are along the spectrum. But yeah, people who have knee replacements most times do great.
Okay.
When everything, I take that back too. You know, you have to be the right candidate too. You know, these doctors take into account, again, obesity, your level of activity beforehand. I mean, if you're healthy and you're mobile and you're working and you're driving and you're not overweight, then you'll probably do great. But again, if you go to a therapist and they evaluate you to see if you have other, you know, muscle dysfunction, then you can work on that as well, just so after surgery, you're in better shape as well. But yeah, people have joint replacements do great.
Okay. And then last question about that study that recommended strongly against manual therapy and massage therapy. Did they give a reason why, and what other research were they taking into account?
Right. And a lot of it too is when you're looking at, you know, I didn't review all the studies that they reviewed. And that was a big thing too for me, like when you're looking at manual therapy, but often it's like exercise and manual therapy compared to just exercise. So it's adding that intervention of manual therapy, it showed no difference really. So that's why they say it's not as statistically significant, because everyone still gets their typical care. So you can't just do manual therapy on one person and nothing on another. Like usually the control group for these exercise interventions, usually it's not no care. So it's always, or I shouldn't say that, because probably some of them are. If you're looking at manual therapy versus no treatment at all, it also, you have to look at what outcomes they're looking at. Sometimes they're looking at pain outcomes, function outcomes, and then they look at outcomes at, you know, 3 months post, 6 months post. So if you're providing kind of like that TENS, if you're providing a manual therapy or just massage therapy, are the effects at 6 months beneficial? You know, so it's all in combination. And we work with a lot of manual therapy because I see it work. We know it works in conjunction with that exercise. So we do manual therapy to help release some of that fascial tissue, or manual therapy to improve range of motion, like working on those pecs, for instance, so we could get better range of motion, so I could start strengthening their back muscles. So if I'm just strengthening their back muscles without doing any manual therapy for the tight muscles, you're not going to be as effective. I mean, we know that, but it's hard to gather some of that within research evidence because it's so specific sometimes, and every patient is so variable. So it is hard to do really structured, really good evidence-based research for therapy because there's so many moving parts.
So, all right. So thank you so much for this presentation.
Thank you all for your time.
Yes, and thank you so much for your time, taking the time to answer all our questions.
Absolutely.
And also thank you everyone for joining us today, and take care and stay safe.
Thank you.
All right, thank you.